Vamos pues a dar comienzo a la sesión en directo de las preguntas y respuestas y permítame antes que nada pues que salude a las dos personas que se comunican con nosotros. ¿Se ven la sala ve a la comunicación, las dos personas que están en comunicación? ¿No? Pues es una pena. Bien, perfecto. Doctor Ángel Cequier, bienvenido a esta reunión y a esta sesión de preguntas y respuestas. And Professor Kosh,
Es un placer.
welcome to be here with us to join our meeting and congratulations for your magnificent talk. We will receive questions from the people present in the room, but also from people who is following us from abroad, from their homes. So I will distribute them to all the speakers just to know the opinion about these questions. Doctor, ¿quieres empezar?
Yeah. First of all, Dr. Kausik, I would like to ask you some comment about the new European guidelines, prevention guidelines, and the role of cholesterol, no HDL cholesterol, as the main target for the score 2 and score all people. With the reason why for including non-HDL cholesterol in this score instead total cholesterol of LDL and maintaining LDL as the goal for the treatment, or at least as the main goal. What do you think about this new regarding the inclusion of cholesterol, non-HDL cholesterol in the score 2?
Yeah, no, thank you. That's an important question. The problem with total cholesterol is that it includes HDL within that. And so women, for example, may have a high total cholesterol with a high HDL component. That risk is going to be very different in somebody else with a high total cholesterol and a low HDL. The ratios don't really work, to be honest, in terms of measurement error and prediction. So the advantage of looking at non-HDL is that you are looking at atherogenic total cholesterol cargo. You're looking at all the ApoB containing lipoproteins. So instead of doctors having to think, oh, right, the triglycerides are high, so the risk is a little bit higher, you're actually taking into account all of the atherogenic cholesterol cargo. Most of it's going to be LDL. I think it probably is going to be a little bit too far to go with LDL in the risk equations, but we are used to looking at targets with LDL cholesterol. If you change your LDL, you will change non-HDL. And if you change those two, you will also change ApoB. So there is a disconnect there. But I think using non-HDL and maybe in the future ApoB is a step forward. It actually captures all risk. But hopefully in the future we'll just move to simplified either non-HDL or ApoB targets. But, it's probably going to take another decade.
Yeah. That's okay, because it is a little bit discrepancy because you base the risk stratification in non-HDL cholesterol, and at the end you have to take in clinical practice the LDL as a measure, or as the main goal, but probably you may change also the goal in clinical practice, but it is yeah.
I have a question for you. This is Lina. Hi. Well, you presented the data of the Da Vinci study. Could you care to explain a little bit more what is the population that was included in the Da Vinci? Because this also gives information on how the treatment is being done.
Thank you. So, Lluís was the national lead, and he was part of that for Spain, so he can also comment. But the idea was to ask the question, Da Vinci was done right between the 2016 and the 2019 guidelines. So what we had heard in every Eurospire study was, hey, let's just use more statins. We're not using enough statins. Let's use more. And we just see it again and again and again. So we asked the question in a slightly different way. So what we said was, half the patients are primary prevention, with all the different risk categories, and half are secondary. And of the secondary, 20% were coronary disease patients because we've studied them well, 40% were cerebrovascular disease, and 40% were being managed for PAD. And from the stable vascular disease, you know, the use of medications and goal attainment was very similar. But what's interesting in that population is that a lot of our patients were actually in primary care. So, you know, a good number were primary and secondary care. And one of the aims was, do we treat the same patients differently between when you see them in a primary care setting and a secondary care setting, so knowledge base, if you will, and how we assess risk. And the bottom line with this, Lina, to be honest, is that it's just maths. And the maths basically is that even when you optimize statin therapy, because we changed the goalpost, you have moved to 55 for very high-risk people. Even if you were to optimize high-intensity statins, you will not get everybody to goal, only 1 in 5. Meaning we've got to start talking, and Lluís has been doing this for many years, talking about intensive lipid lowering and talking about combination therapies. And I think we should be thinking about, you know, as soon as I've assessed risk, very high risk combination therapies, we've got to be thinking about those. And not so much for the moderate and low risk, because we can get there probably with statins, but as soon as you start from 70 and 55. And the other key thing is, for about 50% of our patients, because the average LDL hasn't changed, we've just changed the goalpost, we've made it lower. Mathematically, it is impossible with statins and even ezetimibe alone in 50% of patients to get to 55. So we have to be realistic. Either you're going to use bempedoic acid as a third oral agent, or you're going to use a PCSK9 monoclonal, or if available, you could use inclisiran.
Una pregunta para el doctor Cequier. Él nos ha comentado la dificultad que existe para alcanzar objetivos terapéuticos, y esta pregunta seguramente es común también para el doctor Ray. Y mi pregunta es, ¿cómo es posible que con las dificultades que tenemos para que la gente haga un tratamiento adecuado para obtener las cifras de colesterol LDL en los objetivos que se consideran hoy los adecuados, cómo podemos entender unas guías aparecidas recientemente que nos dicen que debemos abordar el problema en 2 etapas, first step and second step? I mean, this question is also for you. I think you catch the question of 1 steps, 2 steps in the new guidelines, while you are pushing the idea that we should start with high-intensity therapy from the beginning. So how can we conceal these two aspects of these recent guidelines and then the idea of putting everyone on a shot of lipid-lowering therapy immediately after diagnosis? Let Professor Cequier answer first, and then you, if you don't mind.
Okay, si queréis, con la pregunta se me ha hecho en castellano, pues intento responder en castellano. No sé lo que el doctor Ray va a comentar, pero probablemente puede ser susceptible de interpretación. Los datos que tenemos y también los datos que han sido presentados de registros nacionales e internacionales inciden en la sistemática de lo difícil que es conseguir los valores objetivos. Ya cuando los valores estaban recomendados por debajo de 70 ya era difícil. Y además lo importante es saber cuáles son las causas, y las causas probablemente son multifactoriales. El primer step posiblemente es un intento, interpreto, de intentar sensibilizar, de intentar colocar a los pacientes de una manera global con los requerimientos del control de riesgos, fármacos antitrombóticos y también de la reducción de los niveles lipídicos, pero quizás yo interpreto de que posiblemente es mandatorio en aquellos subgrupos de pacientes que quedan de alguna forma en las guías identificados, quizás de una forma no muy precisa, pero es quizás abrir la puerta a intentar identificar y asegurar que aquellos pacientes de más elevado riesgo deben aplicarse las recomendaciones de las guías o los niveles que claramente en estos subgrupos de pacientes aportan un beneficio incuestionable. Esta al menos es la interpretación para quizás aumentar un poco la sensibilidad, teniendo en cuenta la dificultad que hay para conseguir como un primer paso los niveles de un LDL inferior a 50 miligramos por decilitro.
Kosh, what's your opinion about that?
Yeah, I think the way to do it is get rid of step 2. So basically just start, so ACS patients, and I was talking about that, the obvious thing is they're the highest risk group. And you know that 75% are going to be statin naive, 25% already on a statin. We know that the treatment doesn't get intensified. Across the board, everybody coming in, if they're statin naive, gets a statin and ezetimibe. There's no downside to a lower LDL, right? And our biggest challenge has always been implementation. You know, we still don't have that. So let's make it easier. And for the 25% of patients that come in with ACS already on a statin, we know that, for example, their LDL is going to be about 2, that's what the Sweetheart Registry says, 2.1. Going with a stepwise approach from 2.1 with another, I mean, just doing the maths, you're now getting down to 1.5, 1.6. You need another 1 millimole, and that basically means a PCSK9 inhibitor where you're getting 55, 60. Now you take that person down to 0.8. So now you're getting an additional 22% relative risk reduction. So, you know, this whole stepwise approach, just looking at numbers, if we actually move to thinking about risk, it becomes much more practical. So 25% with ACS, if you come in on a statin, you go on to a MAB. For the others, statin naive, statins plus ezetimibe, and then 6 weeks later in rehab, you basically have only one additional step to make.
Si hay preguntas entre la audiencia, por favor, o bien las tarjetas o bien levantando el brazo, aunque no os vemos mucho porque tenemos los focos aquí delante que nos ciegan un poco. Si hay alguna pregunta. Doctor Guijarro eres, ¿no? Doctor Guijarro.
Gracias. Una pregunta también en la controversia de las nuevas guías europeas y la presentación del doctor Mostaza. Para pacientes de más de 70 años de edad, las guías europeas se quedan muy cortos, hablando apenas de estatinas y no van más allá. Y sin embargo, tenemos evidencia también de que al menos retirar el tratamiento para pacientes de edad avanzada se asocia a mayor complicaciones cardiovasculares. ¿Qué hacemos con los ancianos? ¿Debemos tratarlos para las mismas dianas terapéuticas con los mismos instrumentos o tenemos que tener una actitud diferente?
Bueno, la verdad es que no tenemos datos exactos de qué ocurre con estos pacientes, ¿no? Lo que sí se sabe es que estos pacientes, si realmente son pacientes que son ancianos, pero que tienen, después de hablar con ellos y tienen una buena salud, lo que hacemos todos es ponerles tratamiento. Si hay que ir a estatinas moderadas como están o como recomiendan algunas guías, o hay que ir a estatinas de alta intensidad para bajarles el colesterol y meterlos en objetivos, yo creo que no lo sabemos, pero depende del manejo diario que nosotros tengamos y cómo veamos al paciente. Yo personalmente, en mi consulta, cuando veo gente mayor de 75 años y clínicamente están bien, intento conseguir objetivos terapéuticos porque no se ha demostrado que los efectos adversos se incrementen con la edad claramente.
I'd like to make a comment regarding your comments. Obviously, we have to simplify the LDL goal, the LDL strategy at risk in very high-risk patient. In high-risk patient, there is 2 steps: high doses or high potency statins plus ezetimibe, and then PCSK9 inhibitors. And in some patients, triple therapy, only 1 step, that is high potency statin, ezetimibe, and PCSK9 inhibitors. What do you think, Professor Rai and Ángel, about other objectives beyond LDL nowadays in clinical practice? What do you think about other objectives beyond LDL control with this simplified strategy, 2 steps, 1 step strategy? What do you think about other possibilities for cardiovascular risk reduction with other goals in dyslipidemia control? Ángel first, or Guy first, whatever.
Hey, no, please, please.
Okay, so I think we've got to remember that cardiovascular disease is multifactorial, so you have to focus on everything. You know, there's no point in controlling the cholesterol with 2 or 3 drugs if you leave the blood pressure uncontrolled, if the patient still smokes, if we haven't got adequate, if they have diabetes, if we haven't thought about evidence-based treatments that reduce MACE and atherothrombotic risk. So we have to do all of these things. But I think if the question is, I think from an implementation point of view, looking at cholesterol goals, I think we've got 2 agents which are generic, and if we reduce the steps, knowing, in Da Vinci, the use of ezetimibe was 7% as a combination. In the 2 years since, and we presented this last year in the Santorini registry, and some of you have been involved with that, it had doubled to about 16%. How is that enough? And part of this is this stepwise thinking, patient's asymptomatic, let's wait and see what happens. Makes no sense. Our hypertension colleagues don't practice that way. So we should basically get rid of that one step, start with risk. And if we start with risk, instead of just looking at numbers in isolation, we might do a lot better. We will hopefully be starting, Spain's going to be one of the countries and Italy the other, is looking at an app where essentially in ACS patients, you will be able to not just look at baseline risk, but with your different treatment options, your 10-year risk reduction, you can present that in different ways, like absolute risk reduction, numbers needed to treat, relative risk if you want. And you could look at untreated, current strategy with different other add-on therapies. So the question it's hopefully going to look at with a cluster randomized trial is, does actually visualization of risk and benefit actually impact? Is that part of the reason we're so bad, or is it something else? So we'll see.
Yes, only one additional comment. It's one important point of the studies with PCSK9 was that the most important benefit was in the most high-risk patient. In the low or intermediate patient, the benefit was very limited. I agree that it's very important to identify the extreme risk, because this put mandatory the more aggressive strategy. For me, the most important thing is the evaluation of the patient, the risk of the patient. In my presentation, the time in acute coronary syndrome, the time is at the hospital discharge, where we have all the information, the risk, and the prognosis of the patient. For me, the stratification of the risk is mandatory before or at the time of the establishment of the hypolipidemia treatment.
Doctora Badimón.
I have yo tengo un comentario. I have a comment, Ray. Do you have translation? Do you have translation now? Because you are saying, with this, I thought you were understanding. Well, my point is as follows. Bueno, lo digo en castellano primero, first in Spanish. El doble step. ¿Por qué el doble step? I participated in the guidelines for dyslipidemia in 2019. I didn't in the prevention guidelines, and I know what happened. So you have to think that the scenario of the best treatment cannot be achieved if we recommend PCSK9 inhibitors in Serbia, in Croatia, in countries that are not economically potent. So the decision there was to do the 2 steps, at least thinking that the first could be accomplished. This was something that maybe is not rational for us, that we are living in a world that is different, but the people from those countries sitting there were saying that if we don't put things that are easy to get, nothing will be followed, zero. And we had to really reach a consensus there to say, okay, let's then have these 2 steps. What it was introduced was the risk. So for the first time, we were including the different risk patients to say, if you are in Serbia but you have a very high risk patient, maybe you still can find a way of funding the treatment, right? But the point is that all those countries were against to set very stringent regulations because they would not be assumable. So what I'm saying is that the guidelines are a consensus of different countries, different realities, and these different realities has to be encompassed. And it's different what happened in Germany, where the drugs are used immediately, that they are approved, and in those other countries. And now we don't speak about Russia and Ukraine, but these countries also have a problem. And Russia, and they are sitting there in the consensus table. So in a way, this is what I always try to say. When you get upset with the European guidelines, I say you have to think that the realities are different in different countries. And what we have to try as a European society is that the patients should be treated. Let's just start with something and get the physicians with the custom of treating lipids immediately that the patients leave the ward of cardiology. And this is something that it's not possibly reached yet. But we are going to that end, right? That's the point. Because I have heard you say more than one time, why the double step? And I agree with you. Why the double step if we know that the high-risk patient should go as low as possible? Yes. But this is the reason.
This is an interesting way to maintain this group of countries in the east of Europe leading the number of cardiovascular deaths in Europe. So probably it's one good way of doing it.
No, this is not. Because the realities of the countries are economical.
I understand. I was just joking.
Unfortunately.
Let's change the subject if you want, because I have several questions from the audience. And the next one, probably I will address it to Dr. Badimón and Dr. Mostaza. Is what do you think is the role of bempedoic acid in combination with other lipid-lowering drugs in the therapy, in the treatment of cardiovascular disease? Of course, that this has been now complicated because in Spain it has been approved, but it's not going to be financed by the public health system. So, what do you think about bempedoic acid in the new? En español, por favor. El ácido bempedoico, ¿cuál va a ser su uso en la prevención cardiovascular cuando sabemos que ha sido aprobado para uso, pero no va a ser financiado por el sistema público de salud? ¿Cuál va a ser la posición ahora de este tratamiento?
¿Empiezas tú?
Sí, bueno, la verdad es que para mí ha sido sorprendente en el sentido de que, bueno, tiene una eficacia hipolipemiante similar a la que tiene ezetimiba, y una de las críticas que se le ha hecho es que es un fármaco que no ha demostrado reducción en la tasa de eventos, cuando ningún fármaco hipolipemiante que ha salido al mercado había demostrado reducciones previas en la tasa de eventos. Efectivamente, como has dicho tú, Lina, pues la eficacia es limitada porque estamos acostumbrados actualmente a ver reducciones del 50, del 60% en el colesterol LDL, pero yo personalmente creo que tiene su hueco. Y si bien yo soy una persona que cree que la mayoría de los pacientes intolerantes no lo son en sí mismos, no tienen ninguna patología, sino que es el efecto nocebo al que estamos refiriéndonos, es verdad que el que establece quién es el intolerante es el propio paciente. Y tú, por mucho que le digas que se lo está inventando o que tiene algún problema o que no es realmente esto, él dice, mira, sí, podrá ser así, pero yo no me lo voy a tomar. Entonces yo, hoy por hoy, y hasta que esté disponible en los datos de mortalidad que aparecerán el próximo año, yo personalmente creo que tiene un hueco para el tratamiento de los pacientes intolerantes asociado a ezetimiba. Tiene unas reducciones del 35% en los niveles de colesterol LDL, y yo personalmente también creo que se pueden beneficiar muchos pacientes en triple terapia asociado a torva 10 con ezetimiba y bempedoico, reducen un 68% el colesterol LDL. Personalmente creo que sí tiene hueco, pero bueno, yo no sé qué decir en relación con la aprobación del no reembolso.
Creo que hemos más que cubierto el horario previsto, pero no quisiera terminar sin una última pregunta. ¿Hay preguntas aquí?
Sí.
Por favor, allí.
A la doctora Lina Badimón. Si se da tanta importancia a la ApoB, y nos has explicado que hay fármacos que van contra la ApoC, contra la ApoA, y se están estudiando, ¿por qué no se estudian fármacos que vayan dirigidos a la síntesis de ApoB? Pregunto.
Fármacos que dirigen a ApoB, que el
target
target sea ApoB.
Lomitapide.
Bueno, en este momento no hay, pero no... Hombre, es complicado, porque el ApoB, como habéis visto, están muchísimas lipoproteínas, pero evidentemente hay un gen que podría ser un target. En ese momento no hay ningún estudio que lo haya buscado. Y que yo sepa, no sé si se está haciendo en algún lado, pero no sería descabellado, pero también podría ser arriesgado porque podría eliminar formas de lípidos que son necesarias. Yo creo que hemos de pensar que los lípidos son importantes. Lo que pasa es que tenemos que tener maneras de controlar cómo los lípidos funcionan para poder tener nuestros targets. Es llamativo que no hay estudios contra la ApoB, eso es cierto.
Bueno, lo que se observó es que cuando se bloqueaba ApoB, claro, se produce hígado graso porque no pueden expulsar y por eso el mipomersen pues ha sido sacado fuera del mercado, ¿no?
Sí, o sea que es complicado porque hay funciones que no están controladas.
Hemos concentrado, y de hecho debe concentrarse el objetivo en el LDL, simplificar la estrategia del LDL con estatina, alta potencia, ezetimibe, potenciar IPCSK9, incluso como se comentaba aquí, en pacientes coronarios agudos, pretratados o que tienen un segundo evento en el hospital, ya el uso, la posibilidad de IPCSK9. Pero, José, ¿tú qué piensas a día de hoy, más allá de terapias que tenemos sobre el LDL? Bempedoico, como se ha dicho, se ha aprobado, pero no se va a financiar, por lo tanto no se va a usar durante no se sabe cuánto tiempo, hasta que esté el estudio. Pero, ¿qué piensas de otras terapias que sí tenemos? Fibratos, hay varias preguntas, incluso aquí, sobre hacer algún comentario respecto a uso en el año 22 de fibratos, un poco al hilo de todo esto de los remanentes, todo esto que ha salido de los remanentes, y quizás también omega 3. ¿Tú crees que la historia de omega 3, cómo va a ir? Después tú has presentado de nuevo un estudio neutro, esto cómo se ve en el contexto del Reduced, es decir, dos cosas que sí podemos tener a día de 22, ¿tú cómo lo ves en práctica clínica?
Yo en realidad me baso en la evidencia, y la evidencia lo que nos dice es que una vez que has puesto tratamiento con estatinas, el tratamiento con fibratos realmente no reduce la tasa de complicaciones cardiovasculares, si bien todos los estudios que se han hecho en análisis post-hoc se ha identificado un subgrupo de pacientes, que son los que tienen HDL bajo y triglicéridos altos, que sí que se benefician en términos de reducción de eventos. Eso ha llevado a las guías europeas a recomendar en esta población el tratamiento con fibratos, siempre que haya prevención secundaria, y en cambio las guías americanas no recomiendan la utilización de fibratos en estos pacientes hasta que no dispongamos de un estudio. Yo creo que el prominente en ese sentido, que coge esa población en concreto, va a ser importante porque va dirigido a responder a esa pregunta concreta. En cuanto a los ácidos grasos omega 3, pues estamos viviendo un mundo que realmente es difícil opinar. Tenemos un estudio con unos resultados espectaculares y otros muchísimos estudios con resultados negativos. Nos creemos ese estudio, le ponemos todos los peros que le han puesto a ese estudio y no nos lo creemos. La verdad es que es una situación complicada donde yo personalmente, hoy por hoy, me cuesta tomar una decisión, y lo que he hablado con la empresa cuando me han preguntado al respecto ha sido que creo que un segundo estudio financiado por ellos podría solucionar realmente si los resultados fueron casuales, si fue por el mineral o si no fue por el mineral. La verdad es que no lo sé.
Hombre,
¿Algún comentario?
Sí,
la chica
de la María.
está haciendo...
Sí, yo creo que
hay una palabra allí, sí.
¿Sí?
No, que termine si quiere la doctora Badimón y ahora pregunto.
No,
Doctora Royuela.
Que l'OMEMI utiliza unas dosis que es el de Noruega, utiliza unas dosis muy bajas y es docosahexanoico y ecosapentanoico. Entonces es distinto, ¿no? Pero el otro, bueno, los resultados son realmente...
Tenemos
claro,
que cerrar el tema. Última pregunta y despedimos la reunión.
Aprovechando que estáis todos aquí, muchas veces comentamos, ¿no? ApoB va a ser el futuro de lo que vamos a medir. ¿Creéis que lo que debemos medir es ApoB o ApoB partido por ApoA? And the question is if in the future we should measure ApoB or ApoA.
So, Ray?
Kosh, could you answer this question?
Sure.
So, should we measure ApoB or the ratio,
yeah.
BA?
No, never measure the ratios. And the reason for this is that if you actually look at prediction, all prediction algorithms work better if you use things separately. So as soon as you use the ratio, the C statistic, the performance, even though if you have one with two separately versus one using the ratio, they all perform less. So never ever use the ratio. The second thing is that, remember with HDL, the higher it is, you don't get a continuous relationship in terms of protection. It becomes flat, it could even be U-shaped. That's the second reason never to use a ratio. So I wouldn't advocate that. I think, increasingly, ApoV just makes it easier, and it makes it easier for doctors because, as I heard Richard Peto once said, that, B is bad, A is all right. So make it much easier for people to remember.
Okay, I think we
have to close.
Yes.
Thanks, Dr. Wright. Gracias, Ángel. We have to close this session. Y, bueno, anunciar que ahora despedir también a la audiencia virtual. Espero que hayan disfrutado, como nosotros, de esta revisión y actualización de cómo estamos en el diagnóstico y tratamiento de las alteraciones del metabolismo de los lípidos en el año 22. Mañana tendremos una nueva sesión de talleres y de pósters. Por lo tanto, Luis, cierras la sesión de hoy y un poco anunciando.
Thank you, Kosh, for being with us. It has been an honor, a real pleasure. And gracias, Ángel, por estar también con nosotros, a pesar de tus problemas para poder acudir aquí.